5, 4, 3, 2, 1. We are live now.
Okay, good evening, everyone, and this is the third episode of session one of Rising Star of Bombay Orthopaedic Society. And we have session today on pediatric, foot and ankle, and trauma. We have judges with us, Dr. Sandeep Patwardhan, Dr. Tushar Agarwal, and Dr. Chasnal Rathod. And we have a convener, Dr. Sanjay Dhar, with us. Dhar, sir, you can kickstart with welcoming the judges.
Welcome, good evening, everyone. This is my proud pleasure to be here with very eminent faculty here who have consented to be part of this series. Today being the Pediatric Day, we have big luminaries here, Dr. Sandeep Patwardhan, Dr. Tushar Agarwal with us. And welcome to all the speakers who are here as rising stars. As you all are aware that this is a series started by Bombay Orthopaedic Society to usher in new talent and give them the way ahead to be big speakers as well as to make them arrive in the world of orthopedics. So today it is the pediatric and foot and ankle day. We have also with us Dr. Chasnal Rathod, again a big luminary in pediatric orthopedics. I welcome all of you and welcome all the speakers who are lucky to have these three as their listeners today. And I'm sure they should feel proud of it that these big speakers are listening to you. So go ahead and start. And once again, welcome to all the judges. Thank you. Back to Ashok.
Thank you, sir. So there is slight change of order since Dr. Kunal is traveling and has a train to catch. He'll be presenting first on calcaneum fractures, a review of sustained testicular tally approach. You can go ahead and share your screen, Kunal.
Thank you, sir. Sir, is my screen visible?
It's visible. You can make it full screen.
Yeah.
Go ahead. Screen is visible. You're audible. You
Yes.
can start.
Good evening, everyone. I thank everybody and the esteemed faculty and the Bombay Orthopedic Society to let me participate in this competition. I am Dr. Kunal Chaudhari. I did my MBBS and MS from KM Hospital and JJ Hospital and currently doing my fellowship under Dr. Pradeep Munot sir. I'll be presenting today the calcaneum fractures review of subtenticular tali approach and indications and outcomes and complications. So for this presentation, I have done a detailed electronic database study from PubMed and Google Scholar and selected some articles which were relevant to the study, and this included systemic reviews, meta-analysis, and comparative studies. And on the basis of that, I present this case. So sustentacular tali, what is it exactly? Sustentacular tali supports the posterior part of the talus bone head. It is superior surface which includes the middle talar articular surface and connecting to the medial calcaneum facets on the undersurface of the talus. It forms the median border. As in this, you can see that the talocalcaneal joint medially there is a sustentacular tali, which is a prominence on the medial aspect. It is very commonly called as a constant fragment. So why is the sustentacular tali important for us to know? So Wagner in 1993 presented a contact area for anteromedial facet, which included 31% of the subtalar joint and 63% of the loading in a weight-bearing patient had contact of the sustentacular tali. So we know that this data indicated that the medial facet sees disproportionately high loads as pressure increases across the ankle and the hindfoot. So this leads to a scarring and fibrosis of the subtalar joint and reduces range of motion if there is a fracture of the sustentaculum tali. Moving on, why is the sustentaculum tali fracture incidence important to us? These are extremely rare fractures, which include 0.3 to 4% of the total calcaneal fractures. As you can see, this is the constant fragment. So when this gets fractured, Roca et al. approximately that 47% of the isolated involvement and eventually led to subtalar subluxations. So subcenticular tali, which is also called as the talar shelf, these fractures are easily missed, and that therefore we should have a very high incidence of suspicion. Because these are very rare fractures, you have 0.3 to 4% of fractures of the isolated subcentibular tali. This is the largest study which I came across by Dhar and Whip, which they studied 31 subcentibular tali fracture cases, out of which 4 were isolated fractures. But what was very important in these studies is that they told how did the subcentibular tali got fractured. So when do we suspect this fracture is when you get a history from the patient that the foot was fractured in a supination during impaction, or patient had any associated subtalar dislocations or talar fractures or Chopard's fracture dislocation. So that is why we should always get a CT scan, which is must in these cases. Moving on, this is an example of the similar case where you have a fracture of the talus along with the subcentibular tali fracture. In this case, on X-ray, as you can see, it is very easy to miss these fractures. That is why CT scan is very important. Indications of fixation or surgery in this case is that when you see that there is a 2 mm or more step off in the medial aspect, or there is a depression of the medial facet. In this case, however, you can also anticipate an entrapment of the medial structures, that is the flexor hallucis longus, flexor digitorum longus, tibialis posterior. You can also there is also need for fixation when there is a medial posterior facet joint involvement of the fracture. Along with that, when we also do fixation is when we are warranting a surgery such as there is a medial talar fracture, which can also be approached. So from the same approach, we can do fixation of the subcentibular tali along with a medial talar fracture. Next question which we come across, which I extensively found in the literature, was a combination approach. When do we do a medial along with a lateral approach? Normally, as we know, subcentibular tali is called a constant fragment. So when the constant fragment itself is not constant, that means it is not stable. In this, as you can see, that there is a lateral wall fracture, but also there is a subcentibular tali fracture with a step off and some sort of rotation component. So in this, the order of fixation will be first we go and stabilize the constant fragment, make it constant and becomes the reference fragment. And from there, we go on the lateral aspect and do a lateral approach where we fix the rest of the calcaneum in reference to your constant fragment. So that is when we use a combination approach. The approach is very simple. We go ahead with a 5 centimeter incision in a direct medial approach. This is classically described by Whip, and it's a 3 to 5 centimeter incision, which is a horizontal incision, which is centered along the palpable subcentibular tali. If we can't palpate it, the other landmarks will be 2 centimeter below and in 1 centimeter in front of the medial malleolus and just behind the navicular tuberosity. Once we have gone inside, there are some tendons which we come across, and after keeping the tendons aside, we enter the joint space. So what are the muscles that we have to take care of approaching? So superiorly, we have the tibialis posterior muscle and the flexor digitorum longus, which are retracted superiorly, and we take the flexor hallucis longus, which is retracted inferiorly, and in the space between them, we go for this approach. Once we go there, usually in fracture cases, the capsule on the medial side is usually ruptured, so it becomes very easy to access and drain the hematoma. If that is not the case, we can go ahead and do a incision of the capsule and enter the joint space. Care should be taken to avoid any injury to the tibiocalcaneal joint portion of the deltoid ligament, which goes just in that very region, which can be retracted superiorly, and we can enter inferiorly into the joint space. Now, the mode of fixation, if the fragment is very big, we can use multiple screws in a lag fraction, or in a case of combination, we can go ahead with a non-lag positional screws along with or without a plate. So what are the contraindications of this fracture fixation? In case of grossly infected or contaminated wounds, we would not want to fix them. We would want to put them in a fixator. Or if there is any neurovascular deficit, we would go ahead with fixation. We would not go ahead with fixation. If the patient is chronically immobile, we will not do a fixation or any other relative contraindications such as diabetes. What are the advantages? It's a reliable procedure, direct approach. You know that once you take care of the structures in the way, you can easily approach the fragments. Reconstruction of the medial facet becomes very easy. Also, you can approach the medial talar fragments or any talar fractures from this very approach. However, this approach has a pitfall that we can only fix the medial fracture which are displaced, and we cannot do a lateral wall fixation because as compared to a sinus tarsi approach, you cannot very classically see the joint line from the medial approach. Complications, we should be very wary of these complications as they have there is a stiffness in the subtalar joint post-operatively. This happens if we have not properly fixed. Similarly, if we malfix it or we don't fix it properly, the hind foot can go into a varus malalignment. When we place implants, because the tendons go in that very region, they can eventually lead to irritation or injury to the posterior tibial or FDL tendons in that region. A late very known complication, which is told in literature to be around 64 to 68% complication, is that the late entrapment of the flexor hallucis longus tendon in the bony tunnel, and because a lot of callus is thrown post fixation. So we should be wary of this complication. So takeaway from this is that these fractures are very difficult to detect. So we would always go ahead with a CT scan, which is must. The direct medial approach is to be planned for a specific fracture morphology, and it is associated very less morbidity or infection rates. However, always pay attention to make sure that the fracture fixation is anatomical and perfect, and we should also be mindful of the complications. Thank you.
Thank you, Dr. Kunal.
Thank you, sir.
The talk is now open to questions by the judges. Sandeep sir, Tushar, you can stop sharing your presentation.
Yes,
Kunal.
So one question I wanted to ask, sorry.
Yes,
Yes.
sir.
No. This Bombay Orthopedic Society Rising Star is paper presentation, analysis paper, or lecture?
It's a review article on that particular topic.
I did not see any review of articles. I saw a lecture being taken.
Right,
So I think he's missing the context of what he's trying to do here.
right.
Sir,
I guess, Tushar, you have to understand the purpose of this. If you are analyzing, you said you have done meta-analysis and all that, you have to give me some salient papers which have highlighted certain complications or
Yes, sir.
have made certain points. You are delivering a lecture for us.
Sir, the presentation which I'm thank you, sir. I want the presentation which I've made is actually a combination of all the papers which I've read, and this is the advantages and disadvantages which I came across. I have mentioned, sir, what are the reasons to do this approach. However, there was one lacuna which I have mentioned, which I had prepared for this, that there is a lacuna of the outcomes of this approach, because in the literature, this approach has been more often than presented as a novelty approach. So many of the papers, in fact, majority of the papers are just telling how to do the approach and also the need to do the approach. And there is a huge lacuna as to the outcome of doing this approach.
See, if you are going to talk about analysis of meta-analysis and so many papers that you have read,
Yes, sir.
I would expect your slide to tell me that after reading these papers, we find that most of the papers do not comment upon the necessity of doing it or
Right.
the outcome. Means this paper doesn't sound like an analysis of literature. It sounds like you are teaching us about the sustentacular fracture.
Right.
When to do CT, how to do CT, how to do fixation. So it becomes a theoretical lecture. It doesn't stand to the scrutiny of being a review of literature.
I agree, sir.
Yes, sir.
Uh, Tushar sir or Chashnal, do you have any comments?
Yeah. So maybe you may want to collect the articles, then group them into 3 or 4 headings, and then say that these 3 articles were relevant to this particular aspect of this treatment. These 3 articles are relevant to this particular aspect. I think that is a better way. I just wanted to ask, when you are presenting this sustentaculum tally approach,
Yes, sir.
what are you comparing it to? A standalone lateral approach, if I'm not mistaken, a standalone sinus tarsi or an extensive lateral approach to the calcaneum?
Sir, it is comparing more to a sinus tarsi approach, because
Sinus tarsi.
again, extensor lateral approach is not exactly, because in a medial approach, the main reason for the main limitation of this approach is that we are not able to see the joint space clearly. Whereas the very big advantage with the sinus tarsi approach is that you can directly see the joint space, lift the joint up, and then pass your KYS or your fixation devices. However, with a medial approach, you don't get that advantage. That is why it is more of a comparison with the sinus tarsi approach. However, I did not find any paper which compared the outcomes of a sinus tarsi versus a medial approach.
So when you have a patient in which you see a good sustentaculum tally fragment now, you
Yes,
will
sir.
first do a medial approach, fix the sustentaculum tally, keep that as a fulcrum, and then build up the rest of the calcaneum around it.
Sir, no, I will, during my pre-op planning and intraoperatively, I have to keep in mind that or rather I should know the medial approach, but I should also get an idea from the CT scan pre-operatively that whether the medial fracture, medial fragment or the constant fragment is stable or not. Once you start fixing the entire calcaneum on the medial fragment, that becomes your reference. But in cases, if there is a more than 2 mm rotation or step off of the medial fragment, we know that that is unstable. And then in that case, you have to go medially, stabilize it, and then build your rest of the calcaneum up on that medial fragment. So I wouldn't do it in every case, but I should.
So which paper said that?
Sir,
What is the analysis of that paper? That is what we would expect if you're doing review of literature. You have to give me the index paper which said that this is what this says and that is relevant.
Yes, sir. I had mentioned one paper, which is a case report done by Dr. Pradeep Munot sir, where he
So
had.
one case report by Pradeep Minot is not a paper, no?
Yes, sir. There is. I didn't find any case where there was an intraoperative change of plan where they shifted to a medial approach to fix the stable fragment.
Okay. Chashnal, do you have any questions?
No, I think it's fine. And I totally agree with sir that he could have clubbed the level of evidences and accordingly presented the review. So that would have highlighted better.
Okay.
I have one
No
question on
worries.
skin, post-operative skin.
Yes, sir.
Is anybody commenting on post-operative wound dehiscence
So wound dehiscence.
when you're using a collateral approach versus just a sinus tarsi approach?
Sir, that is a different paper which I had read, but it is not part of this study. But however, I read that approach. The comparison between a sinus tarsi versus an extensile lateral.
No. You're mistaking me.
Yes, sir.
As I understand, you're taking a medial approach to fix the sinus sustentaculum tally.
Yes, sir.
And you are taking a sinus tarsi approach to build the rest of the calcaneum on the sustentaculum tally, right?
Yes, sir.
So you
Yes,
have taken 2 incisions on either side of the calcaneum.
Yes,
and
sir.
you have hardware inside the calcaneum.
Yes, sir.
So are you having are papers commenting on
No,
post-operative
sir.
wound
No,
issues?
I didn't. No.
Everybody
I
is
searched.
getting good outcomes in terms of wounds.
Sir, people are not like I haven't found any papers
Any article commenting on the wound?
on this. Yes, yes, that's a lacuna in the literature.
Okay. Thank you, Dr. Kunal.
Thank you, sir.
We'll again start in order and invite Dr. Niranjan to share his
Thank you,
screen
sir.
and start his presentation.
Yes, sir.
Yeah, Dr. Niranjan, you can start sharing your screen.
Is it
Yeah, we can
visible?
see your presentation and we can hear you. You can start.
Hello.
Yeah, we can hear you. We can see your presentation. You can
Yeah.
start.
Good evening, everyone. Myself, Dr. Niranjan. Today, I will be presenting on tarsal coalitions in adults, a review of management option and outcome. So let's get started. Tarsal coalitions are abnormal union of two or more tarsal bone, incidence being 1 to 13%, of which 60% are bilateral, 25% being symptomatic. Majority of them are autosomal dominant. According to they are tissue type. They are classified as bony, cartilaginous, or fibrous. According to location, talocalcaneal and calcaneonavicular are the major contributors. In year 2008, Upasni et al. And in year 2010, Allison et al. Proposed a 3D based classification system for calcaneonavicular collisions and talonavicular collision respectively. Both of these classification are helpful in surgical planning and assuring the adequacy of the resection. Uh, uh, Now, diving into the history of tarsal collisions, there are some landmark articles published. Although the first description of this pathology date back to 18th century by Baffin, it was Harris et al. Who described the relation between the tarsal collisions and the peroneal spastic flat foot in Canadian Journal in 1947. Then in year 1983, Covell et al. Established the connection between the tarsal collisions and the rigid painful flat foot in his article. In 1983, Stormont et al. Published his data on incidence of tarsal collisions and the different types. In 1998, Lumen et al. Put forward the indications and the outcomes of talocalcaneal resections. In 2004, Julia et al. Published a paper on radiographic diagnosis of tarsal collisions. Uh, in 2008 and 2010, Allison and Upasni et al. Proposed a classification for two majorly reported collisions. In 2012, Mosca et al. Explored the role of deformity correction in management of these conditions. Nor et al. In his two articles explored the arthroscopic treatment for the management of the same. For the methodology, I used a PubMed search engine for finding the relevant articles on this topic. With search strategy given above, additionally, snowball sampling was done to find out additional relevant article and landmark paper if there are any. Originally, this pathology described in pediatric population, pain especially aggravated by walking on irregular grounds. Topography topographic topo Topography is site dependent. Most commonly, pain is at sinus tarsi. The examination may or may not show any findings. The rigid plano-valgus foot is a common presentation. CT and X-ray remain the workhorse of making diagnosis. Some of the radiological slides are shown in the slide. Nazim et al. In 2024, in his review article, outlined the management options for the condition in as follows: non-operative modalities like orthosis to diminish the stress due to the unequal distribution, corticosteroids as a symptomatic adjuvant only in the cases of synchondrosis and syndesmosis, purely symptomatic adjuvant, and physio to maintain the joint and to relieve the spasticity of tendon. Author also mentioned the duration of treatment shouldn't exceed 6 months in case of non-responding patients. Anthony et al. In 2023, in his review article, advocated this non-operative uh, treatment gives success rate of almost 85%. Anthony et al. Further stated the decision of operative management is based on following points. One is location of the pain, then the posterior facet joint health, degenerative changes, size and extent of pathology, and degree of deformities. These are few images showing the calculation of heel valgus. So cutoff range set by Mosca et al. Is 16 degree, and medial to posterior facet ratio, which is if less than 50%, then we can go ahead with the joint sparing procedures. Anthony et al. In his review article provided the recommendation given by various literature. Majority of the studies included either are grade B or C, that is level 2 or below. Nazim et al. In his study gave the following treatment algorithm for operative management of coalitions, which basically tells initial diagnosis by CT and X-ray in cases of any queries. We can use MRI or PET scanning. Pain relief being the most common and consistently reported outcome, with secondary outcomes being range of motion and recurrence and return to activity. These are few published studies on the management of calcaneonavicular type, significant of which is the recent one published in 2022, a meta-analysis advocating the conservative management as a first line of treatment, and a symptom relieving is equal with the resection as well as arthrodesis. Similarly, these studies on talocalcaneal collisions comparing the arthroscopy with open surgery, showing the arthroscopy is non-inferior alternative to open surgery in his meta-analysis. And one interesting study published in 2019 suggests all the patients undergoing resection eventually start developing subtalar arthritis on long-term follow-up, that is 5 years, without functional impairment of the patient. In conclusion, tarsal collisions in adult, while challenging, can be effectively managed with the combination of conservative and surgical approaches. A proper diagnostic and tailored treatment will improve the patient outcome. These are my references. Thank you.
Okay. Thank you, Dr. Niranjan. You finished exactly on time. The presentation is now open for questions. Sandeep sir or Tushar sir? Yeah.
Yeah, so what was the average age of surgery in your patients?
So
You read so many articles, no? What was the average age?
So in majority of the cases, the average age is adolescent age after 18 to 25 years.
18 to 25 is not adolescence. Who has defined that as adolescence?
No, sir. So few of the papers are having a patient including 12 to 18 years, and young adults as 18 to 25 years.
No, this basically you're talking of a condition which is a pediatric condition. Why are you
Yes, sir.
calling it adult?
No, his topic was given as an adult tarsal collision.
Yeah, but then he is not talking of adult. No, he is talking of
Exactly.
So
congenital.
So while doing my literature review on PubMed, I was able to find only 15 articles on after doing the search criteria. So after reviewing those articles, majority of the articles give reference to all the pediatric age group articles. That's
Because
why
it is a pediatric condition, it is not an adult condition.
yes, sir.
Somebody's mic is on. Can you shut that? We can't hear.
So I think what he means is it's an adult sequelae of a pediatric condition, right?
Yes, sir.
It is
Yes,
not
sir.
an adult sequelae at all. It is a pediatric condition which is manifest between 10 and 14.
Yes, sir. But as the topic was adult patient, so after 18
But
years,
you
there are
chose
very
the
few.
topic or it was given to you?
No, it was given to them. It was given to them. The topic was given to them.
There is a problem with the topic.
No, it is also pediatric and foot and ankle. So his choice was more.
I understand, but it is basically you don't have adult coalitions. You have
So,
pediatric coalitions.
recent paper published by Nasim et al. Says that there are patients who comes in adult age, that is around 20 to 30 years, because these patients usually built up the stress which is there in
Yeah,
the.
but then you should have included only one paper, Nasim et al.
There is also one more paper on Anthony by Anthony et al. So that paper also
Adult
talk about
hospitalization.
young adults. So the only problem with the paper is they also include the adolescent age as well.
Because
So
it's an adolescent and pediatric problem. Again, I'm trying to tell you something, you're not getting the point.
I'm sorry, sir.
Okay, second thing what I wanted to ask you is that how do you know, you have read the papers now, since you are all talking of review of literature, how do you know adequacy of resection?
So adequacy of resection in case of calcaneonavicular, we have to after doing the resection, we have to see the spring ligament, and in case of
Is
talonavicular,
there a paper? I am not asking you your experience.
no, no.
Since
So
your
that
review of literature, you didn't mention a single paper which spoke about use of intraoperative CT or a navigation or use of O-arm to tell you whether you have completely resected the coalition.
so Anthony,
What are the interpositional materials used?
yes,
How many percent needed osteotomies?
so interpositional material, Anthony et al. Do say about the adequacy of resection in case of calcaneonavicular, and it's seeing the spring ligament, and in case of calcaneal, it's by using a distractor whether we are able to distract it or not. And interposition materials, the paper which I mentioned they have compared the three interposing materials, that is
But
extensor
you didn't
digitorum.
mention a single paper on that in your whole talk. You talk of historic peroneal spastic flat foot paper and algorithms. Where is all the relevant literature then? What I'm asking you. If you're presenting something like this, then you need to tell me the relevant literature, no? You're answering questions now. Your presentation did not consider even one paper. Hello?
Right.
It's there in presentation. Actually, because of the time limit of 7 minutes,
That is the whole idea of the rising star. No, you have to know what is the crux of the presentation. You don't start historical papers and waste time.
yes, sir.
Exactly. I mean, you don't have to classify them. The topic is very specific. Outcomes,
Yes.
management and outcomes of it.
If there is something worthy, you have to get the Amrut from the Manthan.
Yes.
You have been given a topic to churn the literature and give us the Amrut. You are just talking of Vasuki कौन था और मेरू पर्वत कौन था, क्या फायदा है? Sorry, Ashok.
No problem, sir. Okay, Chasnal, you have any questions? You're muted.
I wanted to ask about the interposition materials because he had mentioned one place about the outcomes. So, and Dr. Niranjan, when you're talking about adult coalitions, so were there any comparisons or papers which suggested more of fusion as compared to children when done in adults or something like that? Or was it just the facet involvement which was the deciding factor?
Yes. Ma'am, all the literature I have searched, there were three interposition material which were used. One is extensor digitorum brevis, second one is bone wax, and third one is fat. Among them, bone wax and fat gave a better outcome over extensor digitorum brevis. The extensor digitorum brevis usually have a puckering of skin afterwards. And the usually the recurrence rate was 20% in cases of extensor digitorum brevis cases, and
Was
the
deformity correction done simultaneous or in stages?
the deformity correction given by Mosca et al. Depends on if the valgus angle is there, so calcaneum learning osteotomy is done simultaneously with the resection. And whether to do the resection or not depends on the size of the defect which is there. So if the defect is very large, Mosca et al. Says you can leave the defect and do only the uh, osteotomy or correction of the deformity and continue, the patient will have similar outcomes.
Have you
And
read Dr. Mubarak's papers on resections?
no, sir.
You said you read all the literature, no?
No, sir. Those.
एक 10 मिनट बैठ के पबमेड में जो मिलेगा उसका एनालिसिस कर दिया, ऐसा नहीं करने का. देन यू हैव टू स्टडी द सब्जेक्ट इन डेप्थ.
Yes.
Okay. Tushar sir, you are around?
I think Niranjan has done a good job at reviewing the literature. At his stage of practice and his stage of career, I think it's a very, very good job. And I think from where Sandeep Patwardhan comes also, that's very nice. He is at the pinnacle, so he understands everything much better. But from where Niranjan comes, I think if I was presenting that much, I would have been very happy. It's
You are
not
very
very
kind.
easy,
Tushar,
to
you are very
understand.
kind person.
Whatever you want to say, see, Sandeep, it's not very easy at their level, and I think he's done
No.
a
What
job
I'm
at
saying is that
explaining.
you are trying here to pick the best of the best, right? You are saying rising star.
No. If they are not presenting properly, it is our mistake. We should give better outlines and more crystal clear outlines. Whatever criticisms you are offering, Sandeep, it should be offered beforehand. Because
Before what?
it is not right. No, somebody should have vetted their
Then you have to
presentation.
involve us beforehand. You don't call up last minute and say, come and listen to what people are saying.
Means no. See, we have to vet their presentation. I think whatever Sandeep has said has a valid point, but Niranjan at his level has done a very good job. So Niranjan, learn from what Sandeep has said, and from
Yes, sir.
in future presentation, make a better effort. Try
Yes,
to
sir.
understand what topic has been given to you. But yeah, make efforts to become better, but you've done a great job.
Yes, sir. Thank you, sir.
Okay. Do you have any questions? Anybody else? Okay. Now, these are all whatever suggestions and criticisms are offered. These are all on a positive note. Take it as such, and I mean, it will always help in future. So let's
Boss.
Whatever I am today, it is because of criticisms of Dr. Sandeep Patwardhan. So,
Boss, I am not here to run down anybody. I am just telling you something which is, I think, makes sense. No?
right.
When you talk on, see, I can see I am from Bombay. I consider BOS presentation as the highest level of academia in our country. If you are going to stand on that podium and tell me I am BOS rising youngster or rising star, I expect a certain standard. And I'm just trying to maintain that. I don't intend to pull down your effort. I'm saying that there is much more literature which has been missed, and there is so much more relevant literature which could have been used to make more pertinent points. With maturity, you will come to know what that is. I agree to Tushar that you have made the effort. But then if we just say marks for efforts, then everybody should be getting a rising star. No?
Right. So I think this is also something that further speakers should keep in mind. So let's invite the next speaker, Dr. Niharika. She'll be speaking on pediatric radial club hand. Niharika, you can start sharing your presentation. Yeah, wrong. Niharika, are you around?
बाकी का लोग छोड़ के भाग गया.
We are live, huh, sir?
He's
Niharika,
there online there. Yeah, sharing.
okay, we can share and see your screen. We can't see your video. Okay, we can see you. Go ahead. You can start. Just unmute yourself.
Hello. Hello everyone. Today I'll be presenting pediatric radial club hand centralization technique, terms and complications. What? Arey yaar.
No, go ahead. We can hear you.
I thought I'm not heard.
You heard your thing is seen. Go ahead. The presentation is visible.
So, as a brief introduction, the radial club hand is a congenital longitudinal deficiency spectrum, which can exist from a simple hypoplasia of the thumb up to a severe deformity with complete absence of the radius. It was first described in the 18th century by Petit. The prevalence ranges between 1 in 50,000 to 1 in about a lakh, and about 50% cases are bilateral. It occurs in the intrauterine life between the 4th to 7th week due to an apical ectodermal ridge insult. The methodology that I used to do a review of the literature is that I scanned articles in the last 15 years that were available on PubMed and Google Scholar. I went through meta-analysis and systemic reviews and used whatever articles were available. In the most commonly used classification is the Bain and Clark classification, which was revised in 1987 with 4 types. Type 1 being the mildest one with a mild radius shortening. Type 2, there's a hypoplastic radius. Type 3 is a partial radial absence with a hypoplastic thumb. And in type 4, there's a complete absence of radius and also an absence of the thumb. The Heckel classification has also been used to classify the radial club hand. Let us go through the principles of the treatment. Stretching and splinting has to be started early as soon as the patient is seen in the OPD. Distal ulnar growth and vascularity must be preserved in any surgical intervention that is performed. A functional hand is the best outcome that we can give with a reasonable wrist ROM and a stable wrist. In syndromic patients with associations like the Bactrial syndrome or the Holt-Oram syndrome, the life expectancy of the patient must be kept in mind before we advise any treatment. So the treatment can also be classified in terms of age and severity. In 0 to 1 years of age, serial plastering, soft tissue distraction, and an SOS centralization or radialization can be done depending on the severity. In 1 to 10 years of age, surgery is generally recommended, and more than 10 years of age, distraction lengthening, or if the patient is accustomed to their deformity, it can be left alone. These are the available treatment options for type 1 and 2, which are the milder types. Stretching and splinting it can generally works for patients. Soft tissue procedures such as tendon transfers or tendon releases can be done, and the radius can be lengthened with the help of an external fixator. For type 3 and 4, however, surgical interventions are recommended. Centralization, radialization, ulnarization are some of the commonly performed surgical interventions. For patients with thumb hypoplasia or an absent thumb opponent's plasty or policization also can be done. This is a diagram briefly describing the difference between the 3 procedures. The difference lies between the position of the ulna with respect to the carpal bones. The contraindications for the surgery: older children with an established disease, medical anomalies in which the life expectancy of the patient is hampered, and if there's a elbow contracture in which the elbow stays in extension. So centralization was first described in the 19th century by Sayre, but was popularized by Lamb in 1977 with the aim to centralize the wrist over the distal ulna. Soft tissue release was done. A notch was created in the carpals where the ulna was placed. Tendon transfers were not generally done. This procedure was modified by Watson et al. In this procedure, a K-wire is passed through the lunate, capitate, and the third metacarpal and the same K-wire is then passed in a retrograde fashion through the ulna. Sometimes an ulnar osteotomy is recommended. For this, the surgeon has recommended two Z-shaped radial and ulnar incisions. Some tendon transfer procedures have also been described, like distalization of the ECU and ECR. Let us go through the outcomes now. So Watson et al. Had published an index series in 1984 with a 10-year follow-up of 10 procedures with 9 hands. Serial X-rays were done to monitor the patient's outcome, and they concluded that the earlier the procedure was done, the better the outcome was, as the ulna, there was better cupping and widening of the ulna to accommodate the carpal bones. Next, there's an Indian series which was published in 2011, and it is one of the largest series with 446 hands with type 3 and type 4 Bain and Clark classification. So only severe deformities were included. The patients were managed with surgical interventions like centralization and radialization. Subjective, objective, and functional assessment was performed in the form of VAS, a prosthetic upper limb functional index score, and they concluded that surgical management superseded non-surgical management, and there was an improved appearance and function of the limb post-surgery. Centralization and radialization yielded similar outcomes in this study. Another series that has been recently published by Lahiji et al. Published data with 15 hands, and they concluded that the sagittal ROM, that is the flexion extension of the patient, improved significantly, and the forearm hand angle improved significantly when an early centralization and policization using the second or third metacarpal bone was performed on patients. This is the only meta-analysis that I came across, which was performed by Murphy et al. In 2017 and was published in the Bone and Joint Journal. This meta-analysis included 12 studies, 5 of which were retrospective, 7 were case series. Soft tissue distraction with centralization or radialization achieved the best correction of the deformity, and radialization yielded better outcomes in comparison with centralization. So as we can see in this review of literature that they have performed, centralization gave significant changes in the hand forearm angle, but sustained distraction with centralization yielded better results than only centralization. Some common complications that occur as a result of these procedures are recurrence, which is the most common. Patients can have persistent radial deviation. Some patients can experience stiffness, very short forearm due to an ulnar epiphyseal injury, and wound-related complications such as flap necrosis. In conclusion, centralization is a good surgical option for type 3 and type 4 radial club hands. Early centralization yields better ulnar bone remodeling, similar to that of the native radius. Soft tissue distraction combined with centralization gives better outcomes than centralization alone, and further studies comparing outcomes between the various surgical techniques are needed. Thank you.
Thank you, Niharika. And paper is now open for questions. You can go ahead and ask questions.
Niharika, did you read Dr. Rojuta's article?
No, sir. I unfortunately I not come across it. I did search on PubMed for articles that were recently published.
Not PubMed index, Tushar.
It is published in 2023, Journal of Hand Surgery.
So
Long-term
that
follow-up of ulnar growth in radial dysplasia treated by a combination of distraction and radialization.
So you
I will go through it now after our discussion.
So
then what is the point?
What is any of your articles were telling you about use of Jess fixator prior to
Yes, sir. There was a paper by Dr. Mukund Thatte which described that chest fixator can be used prior to any centralization or radialization procedure, which yields better results because the contracture on the radial side is released to some extent because of with the help of the chest fixator with serial uh, distraction.
And any article which was comparing the exposures, like
Yes,
the
sir.
Xian's exposure or the dual exposure, which you said, or the bilobe flap exposure?
Yes, sir. There was an article that described the evolution of the approaches that were used, like the Z-plasty or the transverse incision, and recently the Evans bilobed incision. So the Z-plasty has more chances of flap necrosis compared to the Evans bilobe procedure.
Niharika,
Yes,
when
sir.
you do distraction methodology and you are adding length to the soft tissue by distraction, right? Do
Yes,
you
sir.
need to do the open surgery at all? What
Uh,
does the paper say?
so that
Do you
depends.
need all those flaps and all? Because do they really help?
So from what I read, the mild deformities could be managed only with.
No, type 4, cycle type 4. When
So
you're distracting the radial side
hmm,
and you're bringing it in center and then percutaneous centralization, have you read about that?
uh, so yes, but most of the literature stated that when distraction was accompanied by a surgical procedure, it yielded better results.
What surgical procedure was that?
So procedure like radialization or
So
centralization.
that's what I'm saying. That is a bony stabilization. What
Yes.
does flap have to do with it when you have distracted tissue and added length?
No,
When
sir.
there is flap necrosis and other complications, why do you need to do any flaps?
Yes, sir. If the skin is
Distraction principle is you are adding length by soft tissue distraction. No,
yes, sir.
you
Yes,
don't do flaps then.
yes, sir.
What does the literature say about that? Necessity of requirement of flaps when you're doing soft tissue distraction. Do you really need it?
No, sir.
And
Less.
what does literature say about ulnocarpal fusion nearing maturity for maintenance of final correction? All these procedures, have very good short term results, 3 to 5 years, but then when you take out the K wire, or it tends to drift back
Yes, sir.
15 to 20 degrees.
Yes, sir.
So a lot of literature is there which has suggested creating a carpal notch and fusing it towards maturity to maintain reduction. You did not mention a single thing about that.
Uh, so yes, I only briefly mentioned that.
No, you did not mention it at all.
So
Even in your conclusion, you never talked, not a single paper on ulnar, ulnocarpal
Not
fusion with
plus.
a notch.
so on only on one slide I'd mentioned it for mature patients or more than 10-year-olds. Ulnocarpal fusion can be considered, but
Only.
I should have
Yeah.
mentioned later also. Yes, sir.
And also regarding role of tendon transfers for tenodesis or balancing.
Yes, sir.
So,
Yes, ma'am.
so you could have highlighted that for the milder deformities at least. Yeah.
Yes, ma'am. So I described it once. I just thought that because the topic was focusing on the surgical indications outcomes, that is why I only briefly mentioned the tendon transfers and all.
Any more questions?
I think all of you know are reading literature very superficially. You need to read it in more detail and understand how the disease is evolving at various stages of the age and what are the complication rates which mandate redo procedure. Congenital anomalies in upper limb are difficult things to manage. Yeah, so small things are there which can be brought out. I just recommend that all of you are now post MS or doing fellowships. No, you have to spend more time understanding the subject rather than doing it like lip service.
Yes, sir.
So Niharika, last question. One contraindication when you will not do any of these procedures for a radial club hand.
Ma'am, one of the contraindications is when the life expectancy of the patient is low, and another contraindication that I can think of is if the patient has an elbow contracture in which the patient cannot flex the elbow at all.
Nice.
Yes, ma'am.
Okay.
Thank you, ma'am.
Anyways, Niharika, you took I think 1.5 minutes more than the allotted time. So again, your main presentation topic was centralization, but you reached that point, I think, after 3 minutes of your time. That should be your primary aim. It should begin with that.
Yes.
Okay.
Yes, sir. Thank
So
you.
let's move on to our next candidate, Dr. Akash Tiwari. Akash, you can start sharing your screen and we can go ahead.
Yes, sir. Just a minute. Am I visible?
Yeah, you're visible. Share your screen. Okay, your screen is visible. You can start.
Good evening, everyone. So my topic is a comparative study for the approaches of the development dysplasia of the hip. So I'm discussing about the medial and the anterior approaches. So just a brief introduction that the DDH is a spectrum of disorders of the hip. Commonly, etiology is excessive laxity of the capsule with a failure to maintain femoral head within the acetabulum. The purpose of the treatment for DDH is to provide early, just a second, sir. Yeah. Is to provide and maintain early concentric reduction without harming the circulation of the femoral head. So we algorithms on that contain various treatment methods according to age and findings have been proposed. So there are conservative treatment methods such as Pavlik harness frequently occur in the first 6 months. Open reduction is usually required if closed reduction cannot be achieved in a child older than 6 months. So the decision is made based on the age and the clinical and the radiological findings. However, it has been reported that a stable hip cannot be achieved through closed reduction in 12 to 43% of the patients. So open reduction is most commonly performed using the medial or the anterior. So I've searched the databases, the PubMed and Web of Sciences Embase, and my keywords were DDH, medial approach, anterior approach, and randomized controlled trials. So, sir, basically, I just, before I go to the analysis, I just wanted to say that there are pros and cons of both.
If I can say, Akash, again, you guys are wasting time.
Right. You need to come to the topic right away.
Yes, sir.
Go ahead.
So the surgical treatment with medial and anterior was performed in these patients who were diagnosed with DDH. So I have combined a few papers. I couldn't find a lot of papers on which the comparison was given on basis of medial and anterior approaches. There were certain papers where there was a medial incision and then the analysis and then the anterior incision and then the analysis. So I've combined a few papers, and the exclusion criteria which I've included was that these were that the potential patients were excluded due to neuromuscular diseases. Age range was around 6 to 24 months, and in which the hips reduction was achieved in gentle manipulation under general anesthesias. So combination of few papers, I've sent that the patients were followed up with somewhere around 2 years, and they were not there was not a lot of difference between the groups of age treatment at the duration and follow-up. There was not a statistical significant difference between the groups with regard to gender and side. The groups were compared with regard to preoperative tonus staging. There were higher dislocations in the anterior group compared to the medial group. And during clinical assessment, there was not a significant difference between the MORs and the AOR groups, which regard to successful outcomes and radiological assessment results. So I've combined a few papers where we can see that there was not a lot of difference in terms of outcomes and complications in these two procedures. And in another study, there was we found that the risk of AVN and FCS are not significantly different between the MOR and the AOR in children up to 15 months of age. Thus, we recommend that the surgeons utilize either technique as they feel comfortable. The risk of AVN following open reduction seems to worsen the increasing age of the surgery and further affirms that significant number of hips undergoing open reduction, almost 30%, will eventually require another surgery. So further research with a larger case control study, I couldn't really find. So there was another paper which said that this paper was in the was a meta-analysis, and it said that the medial approach is a safer and more effective for open reduction in DDH patients of 24 months of age. So our analysis showed that AVN rates are lower with a medial approach than the anterior approach, with similar clinical and radiological outcomes. So my conclusion in this cases would be that the results of this study approaches are similar with regard to clinical and radiological results, and a significant improvement has been achieved in the AI angle using both approaches. So there were not any differences between the groups with regard to AVN and revision surgeries, although tonus staging and the improvement of AI angles was significantly higher in the AOR group. So in conclusion, both methods are effective in this treatment of DDH cases between the ages of 6 to 18 months. However, we have concluded that the treatment should be planned considering the preoperative tonus stage, AI angles, and the preference of the surgeon. Thank you.
Okay, thanks, Dr. Akash. Any questions for him? Tushar sir, Chasna, Sandeep sir.
Akash, I think because Sandeep and Ashok, Shyam interrupted you, you went too fast.
Okay.
Can you just summarize your conclusion again?
So, sir, honestly, in these cases,
No, I'll give you the context.
Yes, sir.
So we have a 1-year-old child
Yes, sir.
and a 2-year-old child.
Yes, sir.
Are the articles telling you what is the preference of surgery in
No,
the
sir.
child less than 1 year
No,
and
sir.
a child roughly 18 months to 2 years?
No, sir.
Okay. So are you trying to tell me that it is totally a personal preference of the surgeon whether to use the medial approach or the anterior approach as per the literature?
As per the literature, sir, as much as I could find out in the literature, there was not a lot of differences between the outcomes with relations to complications and outcomes, which was my topic.
Okay.
So I felt that if you're doing a second stage procedure, it is both the incisions are of the same importance. They have their few pros and cons. With medial incisions, we cannot go into osteotomies of the acetabulum. But again, a con of that is that we might injure the medial circumflex femoral arteries. So, sir, both of them does not give me a clear picture whether which uh, incision or this thing is better than the other one.
Akash, I have a feeling that you people, all of you, I'm not specifically saying you,
Yes,
are doing a very superficial literature review. Your whole presentation starts with as far as I can find. You are already on the defensive, justifying that you have not done a thorough research. It begins with apology, your presentation, which I don't think is right. If you are presenting at this forum, you had better have researched the papers till 2023. And there is enough literature which talks about medial versus anterior approaches, not only the ease of surgery or the AVN rates, but also of bilaterality, about arthrogryposis. Nothing. Your presentation does not have any mention of unilateral versus bilateral, any mention of arthrogryposis. And there are enough papers on that, including Indian papers by Premal in IGO. Right? There is a Melbourne series. There are so many papers on anterior versus medial approach and the outcomes regarding AVN, acetabular dysplasia, quality of reduction, and remodeling potential. You're just brushing it off superficially as if it's somebody has forced you to do this and you're just doing a superficial job of it. Sorry to say, but I'm not at all impressed by the quality of this kind of superstar or BOS star thing.
Right, sir. Any other questions to him? Okay, Akash, thanks very much.
Thank you, sir. Thank you.
Next, we are inviting Dr. Sheenam Bansal for a presentation. Sheenam, you can share your screen and start your presentation.
Okay.
Akash, you can stop your presentation. Yeah, Sheenam, you can start sharing.
Okay, sir.
Okay, we can see your first slide.
Okay. Hello, everyone. So my topic is surgical hip dislocation for slip capital femoral epiphysis. I searched papers from PubMed and Google Scholar. Uh, so uh, uh, we can assess with the surgical hip dislocation. We can visualize entire acetabulum and entire femoral head. Indications of modified Dunn procedures is acute severe epiphyseal displacement with minimal chronic remodeling of the metaphysis. In 2014, in JPO, San Diego, from this paper was published from San Diego. They have modified surgical indication for this procedure to only include patients who have sustained an acute severe epiphyseal displacement. If we talk about outcomes, with the modified Dunn procedure, we can achieve we can restore anatomy. We can achieve normal slip angle, normal alpha angle, and an intact cleans line that indicate the potential of restoring anatomy. This paper was published by Bern University from the Switzerland in 2019 in the Bone and Joint Journal. In this paper, only 2 hips developed avascular necrosis with the follow-up of 10 years. And this paper was published by Bern University from Switzerland, the same university, in 2017 in Journal of Children's Orthopaedics, with no case of avascular necrosis with the follow-up of 12 years. So it reveals the good outcomes. And we can see this is the papers subsequently published by Huber et al., Sankar et al. From HSS from the USA, and Madan et al., Upasni et al. We can see here the mean slip angle was around 5 to 7 degrees and good Harris hip score. In 2014, this paper was published in CORR by Hospital of Sick Children, USA. They compared with modified Dunn procedure with the in situ pinning, and with showed that modified Dunn procedure has good radiographical results. This paper was published by CHOP in 2013 in JBJS. They showed that 26% patients developed osteonecrosis. This paper was published by 2014 by San Diego team. They showed that 23% patients developed osteonecrosis. So if we see these 2 papers have highest follow-up of 12 years and 10 years. And if we see, they have less AVN rates. But these papers were published by USA from CHOP and from HSS and San Diego. They have shown they have shown the high AVN rates. So we can see they also showed that the outcomes depends on the surgeon experience and patient load. This paper was published by by Bern University of Switzerland. If we talk about trochanter non-union, they have advised that trochanteric osteotomy requires more care because they don't have any balancing force. So conclusion is results are good when performed by experienced surgeons. Advanced radiological studies can be done to accurately predict AVN. Need of multi-center study to more accurately predict, because one area of the globe is showing 26% AVN rates, and one area like Switzerland, Bern University is showing 0% cases or two cases with more follow-up. So we need to do multi-center study. Thank you.
Thank you, Sheenam. Paper is now open for questions.
Your topic was safe dislocation or safe surgical dislocation. What was it, Sheenam?
My topic was safe surgical dislocation for SCFE.
Okay. So because most of the papers were not talking about the safe surgical dislocation and the pertinent thing, that's why I asked. Okay.
No, I think all the papers were of safe surgical, no, Sheenam?
Yes, sir. Yes.
So the some were talking about the reduction, then just osteotomy part, and so not all were about safe surgical. That's why.
So let me ask you, Sheenam, you have a lot of access to literature all the time. You think that the term is justified if you have 26 to 40%, sometimes 60% AVN? Is it safe?
Sorry, sir, I couldn't understand. Can you repeat, please?
If you have a AVN rate of 30, 40, 50%, do you
Yes, sir.
think that the approach is safe?
Sir, I think it depends on the outcome. It is not safe, but it depends on the experience, because this procedure.
And what is the paper? Have you read some literature talking about what is the learning curve?
Sir, one paper was published in 2014 by Upasni sir, and this paper has mentioned that if one surgeon has done 28 procedures and they have AVN in one patient only, the other surgeon who has done 3 cases, they also have one AVN case. So they have written in their conclusion that it depends on the patient load, means how much surgeries a surgeon is doing.
No, so that's what I'm asking. Have you read literature which has said what is the average number of cases for learning curve to say that safe surgical dislocation should be done as a standard procedure?
No, sir.
Of course, there is a paper. You have to read it. You know that there is a paper from Boston Children's Hospital, Harvard, where they have restricted surgeons from doing this procedure. They have banned people from doing the procedure. Only one person is allowed to do. You have read that, right?
Yes, sir.
So why didn't you include it? So your whole presentation seemed a little biased to me.
Okay.
If you are reviewing literature, you have to present both sides of the coin.
Yes, sir.
And then you have to make some logical conclusions that though it is called safe surgical dislocation, only one center in the world has shown it is safe. That too is suspect, because they have actually, if you read the paper carefully, what they say is that when they dislocate the hip, they drill the head, and if there is no bleeding, they say that AVN is because of the disease, not because of surgery. And they exclude those patients from their series.
Yes, sir.
So when you are doing that, there is a bias.
Yes, sir.
So Sandeep, should we do safe surgical dislocation at all?
You ask me, I have my own bias because I do anterior, I have only 10% AVN rate. I don't think the safe surgical dislocation is safe at all. It has more complications than a standard anterior procedure. You have non-union of trochanter, you have breakage of implants, you have AVN rates of 40%. You are just looking at one center, and that too it's a bias study. but it has become fashionable. Even more and more, if you read last 3 years literature, more people are saying it is not safe, it is causing trouble.
So, Sandeep, excluding SCFE, is it useful as an exposure for anything else?
Of course, of course.
Yeah.
When you have an unstable slip situation, it is not at all a safe procedure. It's simpler to do a positional reduction, or
No,
there are
no.
papers now talking of gradual reduction and pinning also in situ. Shoneker's paper recently.
No, SCFE, I agree, Sandeep. What I'm
So that's what I'm saying. Other
as
than
an exposure.
SCFE, when the
As an
other
exposure.
time, yeah, if you exclude SCFE for Perthes or head reduction surgery for a large head or
Yeah.
for relative neck lengthening, it is very safe.
Okay. So
Nothing
that means,
happens.
so that means, are you saying that the condition is the SCFE condition is making it unsafe?
Yeah,
Not the exposure.
primarily. No. What I'm saying is that safe surgical dislocation is a very powerful approach which has allowed us to dislocate the hip with reliable understanding of its vascularity.
Okay.
But when you have a situation of an unstable slip, it is
Adding fuel to fire.
it is adding fuel to fire, as well as it is definitely not safe, and it is somewhat of a if I may say, a fashion statement that I am doing this kind of a surgery rather than actual outcomes. Literature does not support it being safe at all.
So you would feel reduction or in situ pinning with osteochondroplasty is probably much safer.
In milder slips, but if you have moderate to severe slips, restoring anatomy is of importance. But there are ways and means of doing it without the safe surgical approach.
Okay.
Which are equally efficient and lesser avian and more familiar. But I think there is so much literature, Sheenam. I thought that you will have read everything and you will present a more balanced view of it. I thought your presentation was highly biased towards it.
Okay,
Maybe the literature itself is biased towards it.
No.
Sorry, Ashok.
He means that she has presented the articles which are biased towards it.
Yeah.
She's not reviewed the articles which are contrarian, right?
Correct.
Yeah.
There are enough papers who have spoken of other ways, including our Venkat's paper or other. So many papers are there.
Yeah.
They have spoken of the head bleeding being not relevant at all.
So
Yeah,
one
we
thing
could
I'm
have
finding is that
taken some Indian papers.
Yeah, that's what, you know,
Rita
because
ma'am's
Means
paper,
when you are
Manda's
saying this is a
paper.
literature
Yeah.
review, no, it was highly biased. You pick up only papers which you feel are like you like and just say that those and then say I didn't find. You have not done a search.
So any other questions? Chasnal, you have something to add?
No, I just said that we could have had more of Indian papers also, like Sir said, Venkat, Mandar, Risha ma'am, Sir, everyone. So we
Yes.
could have got our own perspective also from our epidemiology. So
There are French papers, there are Belgian papers.
yeah,
There's so
they're
much
Belgian
bias,
papers,
no?
right? Even from China and Korea, they also have
Yeah.
lots of papers.
Means
Yeah.
enough people now are saying that this is very dangerous and it's causing a lot of problems.
Okay.
So don't go with the mindset that you have to justify something. If you are going to review literature, do it unbiased. है ना? निष्काम कर्म करो.
Okay. Okay, thanks, Sheenam. And we'll invite the last speaker today, Dr. Omee. Dr. Omee, you can start sharing your screen and start your presentation.
Good evening, everyone. My today's topic is supracondylar fracture. Supracondylar fracture of humerus in lateral pinning technique, only pinning techniques, outcomes and complications. First, I will start with introduction. Definition: a fracture of distal humerus above the condyle, which is thinnest portion of the bone, The common age group is pediatric age group, especially 3 to 10 years of age. And the mechanism of injury is fall on outstretched hand, and extension type is more common in this type of fractures. Clinical presentation is pain, swelling, and deformity, painful ROM, ecchymosis around the fracture site, puckering of the skin, forearm compartment tense, and neurovascular compromise in such rare cases. I would like to classify it as per guidelines classification in the 4 types. Type 1 is non-displaced, type 2 is displaced with intact posterior cortex, type 3 complete displaced, and type 4 complete periosteal disruption with instability in flexion and extension. Diagnosis can be made on the basis of radiographs, AP and lateral views, and it may show anterohumeral line and FED-PED signs on the X-ray. Management, the goal of the management is union of the bone and avoid complication like shown in the image. Management can be done in several types, like in type 1 of injury, splint, cast, close reduction, and milky maneuver will be helpful. In type 2 and type 3, close reduction with pinning can be done. And in type 4, open reduction and manipulation with percutaneous spraining will be helpful. These are the reduction techniques in coronal angulation, moving the forearm, coronal translation, pushing the distal fragment, in sagittal translation, pushing the olecranon, and sagittal angulation, flexing the elbow. Benefits of lateral pinning is it is easy approachable, less chance to neurovascular compromise as ulnar nerve is not in a way. Good reduction, it can give good reduction with lower risk, no incision or visibility requirement, done with minimal instrumentations and lesser rate of infections also. In methodology, I have done these studies with randomized controls and studies and meta-analysis of several articles which are published in journals like in Indian Orthopedic Surgery and many more which is published in Google platforms. First study is 60, it is a one paper when 60 cases of supracondylar humerus fracture type 3 in children operated with close reduction and pinning of the 30 were pinning of which 30 were by lateral approach and 30 were of K-wire cross K-wire groups in January 2015 and June 2017 with minimum 4 months of follow-up periods. Outcome is it gives in 33%, 13.3% in excellent outcome, 40% good outcome, and 46.6 gives fair outcomes on lateral cross pinning. And in as a result of lateral pinning was 6.6% was excellent result, 46.6% was good, and 40% gives fair results. This is second presentation. Case presentation. This is prospective studies done in January 2016 to September 2020. All the patient with supracondylar humerus fracture displaced type 2 and 3 were included. Pre-op, post-op, and intra-op assessment were done with respect to ulnar palsy, Bowman single flange criteria till 10th week of post-op. Total 42 patients are including in this study, in which 28 was male and 14 is female. In lateral pinning, 24 patients. This study we have done shows only lateral pinning. In 24 patients, 2 K-wire was used. In 18 patients, 3 K-wire was used. Plan criteria showed good result in 34 cases and fair result in 8 cases. In immediate post-op to 6 weeks and 10 weeks after surgery. The result is lateral pinning technique with use of 3 divergent pins give a good stable configuration in such also our in supracondylar humerus fracture, also avoiding the risk of ulnar nerve injury. This is the third case which I am presenting. Was conducted to compare the stability of the lateral divergent pinning and lateral parallel pinning in the treatment of type 2 and type 3 supracondylar humerus fracture. A prospective randomized single center study was concluded at the emergency department of Al-Azhar University Hospital from March 2019 to November 2019. Total 30 patients was examined. Among them, 21 was male and 9 is female. The lateral 15 patients are done with the lateral divergent pin, which gives 40 patients give excellent result and 1 patient gives good result. In lateral parallel technique, 15 patients were included, and among them 13 gives excellent result and 2 patients gives good result. The conclusion is, just a minute, there was no satisfactory significant difference which regards to functional outcome between the two groups. Both method produced satisfactory result in all 3 cases. The outcomes is most children regains full ROM and functionality within 6 to 12 months. No growth disturbances are there. Cubitus varus deformity may require corrective osteotomy, and early intervention and proper pinning techniques improves prognosis. The outcomes of the lateral pinning, there are high success rate, good functional recovery, fracture healing is also good. There is lesser chances of malunion and non-union, and it will give cosmetic and aesthetic outcome also. The complications are nerve injury. Radial nerve may be damaged while we are across the second cortex. If proper instrumentation and proper technique was not used, infection may be occur, spin tract infections, and malunion or deformity are also maybe occur. Compartment syndrome, vascular injury, which is very rare, and loss of reduction can be also seen in this type of techniques. Problems in small village like where I am practicing right now, due to lower education, patient first of all does not go to doctors. They are taking self-treatment, or they are taking treatment from hardware. Improper treatment may be done, no follow-up. They are not taking any proper calcium or calcium supplements or any given medication. So due to that, infection rates are very higher. Improper immobilization. They are not keeping cast slab which was given post operative. They are not keeping it properly. And the most important thing is procedure done in small nursing home where the poor assistance or improper instrumentation also available. So due to this like complication like cubitus varus, malunion of the joint, and infection can be occur. These type of strategies which can be reduce the rate of complications. The first of all is regardless of pin fixation technique.
No, Dr. Omee, we need to stop now. You have crossed the time limit. Plus, all this is not relevant to the topic given to you. Again, we can stop here and we can take questions. Tushar sir, Chasnal, Sandeep sir, any questions for him?
So, boss, did you review any paper which says that in this patient you cannot do lateral pinning? Means it's a supracondylar fracture, but you can't do a lateral pinning.
Unfortunately, no, sir.
Okay.
I did not understand what he was trying to say.
Matlab, you are asking me, Sandeep? Or
No, the
Omee?
presentation was a review of literature, no?
हाँ.
Yeah.
तो ये रूरल सेंटर विंटर लो पेरीफेरी एंड स्नो असिस्टेंस वगैरह का क्या रेलेवेंस है?
No, I guess now that goes without saying that all the sort of candidates have probably not really understood their. Uh, we have to probably give them a template presentation henceforth, and then I think they'll do a much better job.
No, I think last two sessions, all the candidates presented very well in orthoplasty and arthroscopy sessions. And that
Okay.
was a template for them also. Most of them joined on Zoom and saw their presentations. And
So
this is
were
the,
these people forced into doing it?
I have no idea. I mean, why are they so unfocused and why are they not? I mean, all of them took a lecture for us. Did not show a review
And they,
lecture at
and it
all.
was all half-hearted. Nobody was interested in really doing it.
So they are Ubharta but not Sitara.
उसके ऊपर भी मेरे को डाउट है उभरता है कि नहीं.
They are all Ubharta but yet to be Sitara. Right? I think
आज
Dr.
के
Ashok.
जमाने में प्रॉब्लम क्या है मालूम है? सबको सितारा बनने का है बिना पढ़ाई किए.
No, I'm sure you encounter them a lot, Sandeep. Yeah.
So, Dhar sir, any comments? You are around?
Okay.
Dhar sir, you are around?
शुगर था. ओके नहीं थैंक यू वेरी मच. आवाज बहुत है.
Okay, sir. Okay, I think all of them have completed their presentation. We'll thank them for their effort and hopefully they do better next time. So I'd like to thank all the judges, Chasnal, Tushar, Sandeep sir. Thank you very much for sparing time with us and hope to see at least one or two of them in Virok also. Thanks.
I have learned a lot from all presentations and from Sandeep's criticism. Means I am suddenly feeling so wise.
I am very
Thanks a
sorry if
lot,
I have
Ashok, for
criticized it too
involving me.
much because I feel that I have come up from that same school of thought and I think we need to pull up the standards. We are accepting too much of not really star material as
Nee, I
we
got
have
your
to
point,
make.
but I feel probably somewhere we are lacking. We should have been teaching them, telling them, mentoring
Whatever.
them. Yeah.
So these
I
are
don't
the
want to put blame game. I'm just giving you an unbiased opinion of what a standard should be.
right.
So guys, if you are still around, the presenters, I think what Dr. Sandeep is trying to tell you is understand your topic very clearly. Okay. And then clarify it in your head. What are you going to be speaking on? Noticing your audience. And take a mentor and vet your presentation with a mentor before. So then it would be probably much better.
Yeah.
First thing is when you do a series, a review of literature, you should do it for the last 5 years. Right? You can't talk of historical classification ka paper. You think that is the relevant thing today?
Absolutely. They were all given very focused topic and they need not stray at all to anything except the topic
So,
and enough literature.
yeah, so it looks as if you are writing a theory paper answer or something like you feel that the person who is your examiner or your doesn't know anything.
Right. Anyways, I'd like to thank our judges and our participants again. And we end our session today for this BOS Rising Star Session 1.
Okay, thanks, Ashok.
Thanks, sir.
Thank you everyone.
नहीं बराबर बोल रही है ना, हमने क्यों नहीं रखा? ये कौन हैंडल करेगा? किसी ना किसी को तो देखना चाहिए था ना।